Bismillah ar-Rahman ar-Rahim. Now we are going to start this session. It is 1.25 hours late. So, as we are going to start step for virtual clinic for teenagers. يعملوا صوت فين الصوت؟
Ud Youssef Ali Ahmed Abdallah, Obstetrics Gynecology Department, Faculty of Medicine Ain Shams University. Creating a virtual clinic for teenagers in Egypt requires careful planning, adherence to local regulations, a deep understanding of the unique needs of adolescents, vision to be the leading and most trusted virtual healthcare provider for teenagers in Egypt, fostering their physical and mental well-being through accessible, confidential, and youth-friendly digital services. Mission: to provide high-quality, convenient, and compassionate virtual medical and mental health services specifically tailored for adolescents, empowering them to take an active role in their health journey and addressing their unique concerns in a safe and supportive online environment. Target audience and services. Target audience: teenagers, ages 13 to 19, in Egypt, with a focus on addressing common adolescent health concerns. Consideration should be given to different socio-economic backgrounds and geographical locations to ensure accessibility. Core services: mental health support, individual therapy/counseling for anxiety, depression, stress, body image issues, academic pressure, peer relationships, family dynamics, etc. Group therapy sessions for common challenges, e.g., social anxiety, exam stress. Parent/caregiver coaching and support sessions. Medication management, if appropriate and legally permissible, with psychiatrist oversight. General health consultations. Minor illnesses, colds, flu, allergies, skin irritations like acne. General health advice and education, nutrition, sleep, hygiene. Sexual health education and counseling, age-appropriate and with parental consent where legally required. Prescription refills for non-controlled substances, with appropriate medical review. Wellness and preventive care. Personalized health coaching for healthy habits. Educational resources on various health topics, e.g., vaping prevention, cyberbullying, healthy relationships. Mindfulness and stress reduction techniques. Legal and regulatory compliance, Egypt-specific. This is a critical area and requires thorough research and consultation with legal experts in Egyptian healthcare law. Telemedicine recognition. Telemedicine is legally recognized and increasingly integrated into the Egyptian healthcare system with an evolving legal framework. Electronic signatures and data protection. Electronic Signature Law Number 15/2004 recognizes electronic signatures as legally binding. This is crucial for consents and medical records. Cybercrime Law Number 175/2018 safeguards patient data and medical records shared digitally, penalizing unauthorized access and data breaches. Data Protection Law Number 151/2020 sets stringent guidelines for data collection, processing, and storage of personal data, ensuring privacy for sensitive health information. Medical ethics and professional conduct. The Medical Syndicate Law Number 45/1969 extends to telemedicine, emphasizing competent, ethical, and professional medical care. Consent for minors. This is paramount. Parental consent. In most cases, explicit parental or guardian consent will be required for minors to receive virtual healthcare services, especially for medical consultations and mental health therapy. The specifics of this consent, e.g., who can provide it, how it's documented, need to be clearly defined and legally sound. Teenager assent. While parental consent is often legally required, obtaining the teenager's assent and ensuring their understanding and willingness to participate is crucial for effective care and engagement. Confidentiality. Carefully navigate confidentiality laws concerning minors. While parental consent is needed, assure teenagers of their privacy within legal boundaries, e.g., what information is shared with parents, and when confidentiality might be breached due to safety concerns. Licensing and accreditation. Provider licensing. All healthcare professionals, doctors, therapists, counselors, must be licensed to practice in Egypt. Clinic accreditation. Seek accreditation, e.g., through URAC, which offers international telehealth accreditation in Egypt, to demonstrate adherence to high standards of quality, safety, and accountability. This builds trust and ensures best practices. Insurance coverage. Understand how current health insurance laws, e.g., Health Insurance Law Number 99/1995, might cover telemedicine consultations and treatments for teenagers. Advocate for comprehensive coverage. Emergency protocols. Establish clear protocols for handling medical and mental health emergencies, including situations requiring in-person intervention or crisis support. This should include how to connect users to local emergency services. Platform and technology. Secure and user-friendly platform. HIPAA-compliant or equivalent Egyptian standard essential for protecting patient privacy and data security. Video conferencing. High-quality, reliable, and encrypted video calls. Secure messaging for non-urgent communication between teens and providers. Online booking and scheduling. Easy for teenagers or their parents to book appointments. Electronic health records, EHR, securely store patient information, medical history, consultation notes, and treatment plans. Must be interoperable if possible for referrals to traditional healthcare facilities. E-prescribing, secure system for sending prescriptions to pharmacies. Payment gateway, secure and convenient payment options. Interactive features, incorporate engaging elements like digital worksheets, goal-setting tools, and educational resources tailored for teens. Technical requirements for users, clear guidelines on necessary devices, smartphone, tablet, computer with camera/mic, and internet speed for optimal experience. Technical support, dedicated support team for troubleshooting technical issues faced by users and providers. Data protection and privacy, crucial for teenagers. Personal Data Protection Law Number 151/2020, PDPL. This is the cornerstone of data protection in Egypt and aligns with international standards like GDPR. Key provisions relevant to a virtual clinic include explicit consent. Processing of personal data, especially sensitive data like health information, requires the explicit consent of the data subject. Sensitive data. Health data is explicitly categorized as sensitive personal data under PDPL. Processing such data requires prior licensing from the Egyptian Data Protection Center, DPC, and the data subject's consent. Data collection and purpose limitation. Data must be collected for specific, legitimate, and declared purposes. It cannot be retained longer than necessary. Data security. Organizations must implement robust security measures to protect personal data from breaches, unauthorized access, or disclosure. Data Protection Officer. DPO organizations processing large volumes of data or sensitive personal data are generally required to appoint a DPO. Breach notification. Data controllers and processors must notify the DPC within 72 hours of becoming aware of a data breach and notify the data subject within 3 days. Extraterritorial reach. The PDPL applies to entities processing personal data of Egyptian citizens, regardless of whether the entity is located inside or outside Egypt. Digital forms and questionnaires. Purpose. 4 intake forms, consent forms, crucial for parental consent in Egypt, pre-session questionnaires, symptom trackers, and feedback surveys. Key features. Secure digital signatures. Legally binding electronic signatures for consent, supported by Egypt's Electronic Signature Law Number 15/2004. Conditional logic. Forms that adapt based on previous answers. Integration with EHR. Data from forms automatically populates the patient's record. Teenager considerations. Easy to complete digitally, often more engaging than paper forms. Hybrid communication, involving parents/guardians. Separate patient and parent portals/access. Purpose. To manage access to information based on consent and legal requirements. Key features. Parent/guardian account. A dedicated portal for parents/guardians to manage appointments, make payments, sign consents, and access parent-approved information from their teen's chart. Teenager account. A distinct account for the teenager to manage their own appointments, if given permission, access educational resources, and communicate directly with their provider. Consent granularity. System to allow parents to grant consent for specific services or types of information sharing, e.g., they consent to therapy, but only specific information from sessions is shared with them. Egyptian context. This is vital for navigating parental consent requirements, PDPL, civil law implications, while respecting the teen's privacy where ethically appropriate and legally permissible. Clear policies must outline what parents can and cannot see. Parent-provider secure messaging. Purpose: for parents/guardians to communicate directly with the clinic's administrative staff or their teen's provider regarding logistical matters, concerns, or updates that do not breach the teen's confidentiality agreement. Key features: encrypted, auditable messaging system within the portal. Staffing and training. Multidisciplinary team. Physicians, general practitioners, pediatricians, mental health professionals, psychologists, psychiatrists, licensed counselors, social workers experienced in adolescent health, nurses, for triage, basic advice, and follow-up, care coordinators/navigators, to assist with scheduling, understanding services, and connecting patients to other resources. Technical support staff. Specialized training. Adolescent health. All staff working with teenagers should have specific training in adolescent development, common health issues, and effective communication strategies for this age group. Telemedicine best practices. Training on virtual consultation etiquette, maintaining rapport, conducting assessments remotely, and managing technology. Confidentiality and privacy. Rigorous training on data protection laws and ethical considerations when working with minors. Crisis intervention. Training for all staff on recognizing and responding to mental health crises and suicidal ideation. Cultural sensitivity. Training on cultural norms and
1. Website and mobile app. This is the central hub for all interactions. Information Hub provides comprehensive information about common gynecological issues in age-appropriate language. Includes FAQs, articles, and videos on topics like periods, discharge, hygiene, and puberty. Service descriptions clearly outlines the services offered, such as virtual consultations, educational resources, and referral processes. A provider bios introduces the healthcare professionals, all female and specialized in adolescent health, with their qualifications and a friendly photo to build trust. A privacy policy and terms of service transparently communicates data privacy practices and user guidelines in an easy-to-understand secure messaging/chat feature. An asynchronous communication tool that offers flexibility and discretion. Direct messaging with providers allows teens to send non-urgent questions to their assigned healthcare provider, fostering continuous communication outside of scheduled appointments. This is ideal for follow-up questions or clarifying instructions. A pre-appointment chat. Teens can chat with a virtual assistant or a care coordinator to help them prepare for their appointment, clarify technical requirements, or get answers to administrative questions. Asynchronous consultations. For very minor issues or quick questions, a brief chat 3. Video conferencing, telehealth platform. The primary mode for live consultations. One-on-one consultations. Secure, encrypted video calls with gynecologists or nurse practitioners. The platform should be user-friendly, reliable, and accessible from various devices, smartphones, tablets, computers. Screen sharing. Providers can use screen sharing to show educational diagrams, explain lab results, or demonstrate self-care techniques. Virtual waiting room. A private, secure waiting area that replicates the in-person clinic experience, ensuring privacy before the consultation begins. 4. Interactive questionnaires and forms. Essential for gathering information efficiently and discreetly. Pre-consultation symptom checkers. Digital forms, like the ones we discussed, that teens fill out before their appointment, covering specific symptoms related to abnormal bleeding, discharge, or pain. This helps the provider prepare and makes the consultation more efficient. Consent forms. Digitally signed consent forms with clear options for parental consent when legally required, ensuring compliance and transparency. A feedback forms. Post-consultation surveys to gather feedback on the experience, helping to continuously improve services. 5. Email and SMS notifications. For essential updates and reminders. Appointment confirmations and reminders. Automated emails and SMS messages to confirm scheduled appointments and send reminders closer to the appointment time. Follow-up instructions, sending post-consultation summaries, care plans, or prescription details via secure email with appropriate security measures. Educational content alerts, opt-in notifications about new articles, workshops, or relevant health information added to the platform. 6. Educational content, blogs, videos, infographics. Proactive communication to empower teenagers with knowledge. Blog posts/articles. Easy to read articles on a wide range of gynecological and adolescent health topics, addressing common myths and providing accurate information. Short educational videos. Engaging animated or live action videos explaining complex topics in a simple, visual manner. Infographics. Shareable visual summaries of key health information, often distributed via social media. Live Q&A sessions/webinars. Moderated online sessions with healthcare professionals discussing common concerns, allowing teens to submit questions anonymously. 7. Social media presence. To reach teenagers where they are and build community. Informative posts, sharing snippets of health information, myth-busting facts, and positive body image messages. Interactive content, polls, quizzes, and opportunities for general, non-personal questions. Awareness campaigns, promoting awareness about gynecological health and the clinic services in a relatable and non-stigmatizing way. Community building, creating a supportive online community where teens feel understood and less alone. Note: direct medical advice should never be given on public social media platforms. Consultation might be offered as an alternative to a full video call. Format:
Sensitivities relevant to Egyptian youth. Marketing and outreach. Youth-friendly branding. A name, logo, and messaging that resonate with teenagers. Digital marketing. Social media campaigns, Instagram, TikTok, Facebook, with engaging content. Targeted online ads. Content marketing, blog posts, short videos on common teen health topics. Partnerships. Schools offer workshops or informational sessions about the virtual clinic. Youth organizations and community centers. Pediatric clinics and family doctors for referrals. Parent groups and online forums. Awareness campaigns. Address stigma around mental health, especially among teenagers and their families. Highlight the convenience and privacy of virtual care. Financial model. Pricing structure. Consider various options, per session fee, subscription models, tiered services. Insurance acceptance. Work towards accepting major insurance plans in Egypt. Self-pay options. Offer competitive rates for those without insurance. Funding. Explore grants, partnerships, and investor funding. Monitoring and evaluation. Key performance indicators, KPIs. Number of consultations, general health, mental health. Patient satisfaction rates, teenagers and parents. Treatment adherence and outcomes. Wait times. Website/app usage and engagement. Referral rates. Regular audits. Ensure compliance with legal and ethical standards. Continuous improvement. Use data and feedback to adapt and enhance services.
Thank you. Next speaker, Professor Jean Depast from Belgium is going to present how does artificial intelligence work and helps you for transperineal ultrasound imaging.
Thank you very much, Mr. Chair. Can I ask you how many of you are doing transperineal ultrasound of the pelvic floor? So I'm glad that there is one, and I hope the others will join after they hear how we have made tools to make that better. I have to declare that we have been working with the medical industry, and particularly with GE, and some of the software that you will see is today on their machines. I will tell you a few words about AI, but mainly about AI in pelvic floor imaging. The challenge of 3D and 4D ultrasound, which is required for transperineal ultrasound, is much larger than for 2D image analysis. I will focus on the two muscles that are currently best studied, that is the levator as well as the anal sphincter. We will talk about automatic segmentation algorithms, how we can avoid litigation by interacting with the algorithm, and then I will also show you how that works on the anal sphincter, and I will finish with the development of a tool that will do quality analysis. You probably know what AI is because in your daily life your telephone, your computer is already doing tasks that you associate with a human being. A deeper form of that is machine learning, where a computer is given a certain task that we would do and is given data that are annotated or not annotated to learn to do that task. The most advanced way of AI, and that's the use in medicine that is the most popular, is so-called deep learning, where the computer, without any education or pre-existing knowledge, makes decisions based usually on pattern recognition. This is how the computer works. If you give them images of these plans, you in your brain within seconds have already drawn a left and a right, because there are clearly differences between these images. How does a computer work? Well, it starts to look like you, but it has to look in a different way, so it scans the image and takes all the feature into its brain. And you probably have classified the plants based on the different in the leaves, because in the right hand side there were no leaves. And so you make plants that have big leaves and others have small leaves. This is called feature extraction. Now, I did mislead you, because the difference could as well have been in the color of the pots that are under the plants. These are called confounders in the image, and therefore a more accurate way of discriminating would be better, these plants. This is how the computer works. On the left you see an image from a bike, and the computer captures these images, analyzes it in a way that we don't understand, and at the end of the day, on the right hand side, it generates the bike, which is typical, visible here in this information of the picture on the left hand side. So it transforms a matrix into a new matrix that it can work with. And it learns about the relationship, how to go from left to right. Now, in transperineal ultrasound, we do several things. We typically use it in a 2D view. That is the easiest way to process, and what we do is we measure certain landmarks in reference to a point of reference, which is the symphysis pubis in this. And we measure how much there is descent and mobility and so on. But in transperineal ultrasound, we are more interested in using the 3D feature, and we will actually let the patient do certain movements. So we are also interested in the time changes in these volumes. And so, for instance, things we will measure is the plane of minimal hiatal dimensions, which is a predefined plane that goes from the symphysis pubis to the levator ani muscle anterior border. There are two muscles that we are clinically interested in. It's the levator ani muscle, which can be by birth trauma torn, and then in that case we speak about avulsion of the levator, which can be uni or bilateral. But the muscle can also be traumatized more locally and all over the muscle, and this is called microtrauma. And when that happens, you get a kind of laxity of the tissues, and you can see on the right hand side, while the patient is pushing, that the hiatus opens. This is what you know when you clinically examine a patient, but it can quantify that. Now, to do these measurements and to filter out these planes, you will manually select that plane of minimal hiatal dimensions, taking these landmarks into account. Now, is this an important measure? Well, avulsion. It predicts pessary failure. It also predicts recurrence of prolapse. And the continuous feature, which is hiatal widening, also is a predictor of recurrence of prolapse. And all of this is also related to subjective outcomes. So that is the clinical relevance of that measurement. What we have been doing with our group, and I will summarize that so that you know what the clinical value is, that we made an algorithm that can automatically extract from the image the measurement of the hiatal area. When you use that algorithm, you'll save at least 2 minutes of analytical time. And the accuracy of the machine is actually the same as the accuracy that an expert has when they consequently analyze the same image. And it is a fully automated feature which is now in the machine. And you can see, for instance, here the green and the red, the differences between the manual and the machine generated context. Now, because this is dangerous from a medical viewpoint, but mainly from a legal viewpoint, we have made the tool interactive. And you see a video now that shows the machine suggesting something to you, and it will ask you to interact to make the necessary corrections, so that at the end of the day you have a human interference and you responsibility taking for the generated end product. And that is necessary if you ever go to the market with that. The last tool for the elevator that we have made is that it can watch at a dynamic video, and that it can snapshot exactly the time point in the sequence that the patient is maximally contracting the muscles. And this is a tool that we will now make into a homemade device, so that patients, for instance, can measure as a kind of biofeedback the way they are contracting. I told you that I would speak about the anal sphincter because I think in the obstetrical world this is a much more important thing, because anal sphincter injuries are still clinically a problem, and problems that we have difficulties to recognize and treat. Now, this is a typical transperineal image, which is done in the opposite direction as with the prolapse measurements that I showed you before. And you can see on the top the mucosal folds in the middle, then a whiter and a darker ring, which is the internal and then respectively the external anal sphincter. And on the left, you see a image in one direction. On the right top, you can see a sagittal view, which hopefully catches the entire anal sphincter, and then a frontal view at the bottom. Now, out of this, on the left, you can see here how this muscle can be segmented in there. These are all normal muscles, and you can see both its length and its features for the internal and external sphincter. And you do this by manipulating this volume to make tomographic sequences through that volume. And what can also be done is on the right hand side, if there are defects in each of these tomographies, we can measure the angle of opening, and there is an international standardized definition that in 4 planes there has to be a significant defect before you consider it as a typical anal sphincter defect. Now, how does it work? Again, the pipeline, which happens in the background, you acquire the volume, and what the machine does with this convolutional neural network that I showed at the beginning, it will try to find areas and in the volume that it will segment, and it will at a given stage agree with itself on defining that volume. What it then does with a more improved algorithm is making that more accurate, and then we typically allow the user, the clinician, to interact and make corrections in all the planes of relevance, and then you have the red end product, which will be the sphincteric volume. Now, you probably remember from the early days of 3D volumetry that in the vocal sequence that you have on your machines already for 15 years, this is what you would get if you would use that. But on the right-hand side, you can see that the end product is a more accurate, you have to believe me for that, a more accurate volume than the left-hand side, and that is because this algorithm is used. But what is more important is your time, and you can see here that this is mentally much less distressing The NASA score is a score that measures mental distress, and also in terms of time demand, this goes much faster. Now, to finish, what we also have done is made an algorithm that out of a volume will by itself extract the tomographic slices which you need to make your formal diagnosis. Now, how does it work again? And this is the last time I will tell or explain you how the machine thinks. You acquire the volume. So based on training, it has been able, with using that convolution neural network, to segment out in all the planes the muscle mass. Then in the sagittal view, it will try to define the midline, and then it will automatically take slices to the left and the right, and it will come with an overlapping segmentation. This segmentation will then be rotated, which is what you normally do in 3D, and when it is horizontalized, we actually try to define the upper and the lower border of the anal sphincter. That distance is then divided in the number of slices you want to take. This is what you do without thinking while you are making this manually, and this is the automatic two extractions that it has made. Now, this has been shown to improve the workflow by a factor 4. It is hyper accurate, and it can be completely automatic if you want, or interactive if you would like to use and correct it. And for instance, this is in a study that we've done. We asked the machine to generate itself a diagnosis, and the agreement between the machine and the clinician expert was over 90%. So they identified the same volumes. But what is even more interesting, if you, who are not used to use this modality, would make the diagnosis, you would miss half of the sphincter defects. But if the machine helps you, you nearly find them all, or you will not wrongly assign a normal sphincter to the group of the sphincter defects. And it can be fully automatic, and it takes exactly 2.5 seconds. The last thing it will do, and these are projects that are ongoing today, is that the machine would generate for you automatically a diagnosis. You make a volume, and the machine will say avulsion or sphincter defect. This is extremely interesting in a labor suite, for instance. When somebody can do a scan, it will automatically give the diagnosis, and they know they need to call for help. But for that, on the right-hand side, of course, the machine would also need to be able to tell you that the volume you have taken is usable, and that the volume meets certain criteria. And here you can see a few things that the machine says. You're off-centered, you have acoustic shadows. So all of this, when you combine this can become a fully automatic sequence. So I would like to thank you for making a bit of time for research that translates into clinical practice. I have the fortune to work with 3 engineers, and having a sponsor like General Electric who wants to provide us enough money to generate these products. And these are the universities we collaborate with. I thank you for your attention.
We move to prevention of over and under diagnosis of adolescent polycystic ovarian syndrome, evidence-based guideline. Professor Muhammad Imam.
بسم الله الرحمن الرحيم. طبعا بقدم الشكر للأورجانيزنج كوميتي for opening me for this talk. My talk today is prevention of over and under diagnosis of adolescent polycystic ovarian syndrome, evidence-based guidelines or guidance. WHO definition of adolescence is the period of physical and psychological development that is within 8 years from menarche. So the pathogenesis of polycystic ovarian syndrome in adolescents need two hit theory. The number polycystic ovarian developed when two hits are triggered. The first hit is genetic and acquired at the same time by maternal androgen. And the second hit is epigenetic factor which propagate the first hit by insulin resistance. Adolescent polycystic ovarian syndrome diagnosis is after 2 to 8 years after menarche by two items only by Rotterdam criteria, hyperandrogenism and irregular menstruation. In the adulthood, need another item which is polycystic ovarian morphology or AMH. In adolescent, hyperandrogenism only and irregular menstruation and not need polycystic ovarian morphology or AMH. And after the exclusion, the mimics, which are very important at that age. The rationale of my talk as the features of normal adolescents overlap with diagnostic criteria of this age. The challenge is to prevent delayed under or overdiagnosis. This is our talk and the aim of our talk. My objective is to raise the awareness of evidence-based guidance for optimizing diagnosis of adolescent polycystic syndrome by avoiding the underdiagnosis and the overdiagnosis. And at the same time, it is accurate diagnosis at the same time. The source of my evidence is international evidence-based ISHRI guidelines 2018 and 2023 and systemic review and meta-analyses till April 2025. Number one, how to avoid the underdiagnosis. 4 items very important for you. Number one, picking up at-risk children. So the diagnosis of adolescent polycystic syndrome starts from childhood. Number two, polycystic ovarian morphology not essential for diagnosis, and the anti-malarial hormone also not essential. And after that, follow-up of at-risk adolescent. Many adolescents are at risk but not diagnosed as polycystic ovarian syndrome at this age. Regarding the picking up at-risk children for this syndrome, 4 items: childhood obesity, childhood epilepsy, and the hysteresis hair. That epilepsy is a risk factor at the childhood and the premature birth, and the family history of syndrome, this syndrome, diabetes, alopecia, and the maternal obesity during pregnancy. If the mother is obese during pregnancy, you should expect and suspect that the female child may catch polycystic ovarian syndrome after that. Number two, polycystic ovarian morphology is not essential like adulthood by Rotterdam criteria due to the high prevalence of what is called multifollicular ovary, and you should know the difference between multifollicular ovary and the polycystic ovarian morphology. In this life stage, about 30 or 25% has multifollicular ovary, not polycystic ovarian morphology, and this is a transient condition, not persistent condition. This table shows us the difference between the two. Multifollicular ovary has cysts fewer than 12 cysts per image, and the cyst diameter more than 10 millimeter. But in the polycystic morphology, from 2 to 10 millimeter. And the osteoma not increased, and this is reversible stage like this big. Anti-malarial hormone not diagnostic like adult. Now, the anti-malarial hormone can diagnose polycystic ovarian morphology, and you may not in need for polycystic morphology by sonar in adult. But in the adolescents, this stage of life is dynamic, not static, and also lack of accurate cut-off value based on large and different adolescent population. So till now, not be keen to start the diagnosis by AMH in this age of life. Number 4, follow-up of adolescents at risk of polycystic ovary syndrome presented by one only diagnostic criteria. I said to you that the two diagnostic criteria, irregular menstruation and hyperandrogenism, can diagnose this syndrome among this age. But if one of these criteria is present, there's like isolated menstrual irregularity, but not hyperandrogenism, but not irregular menstruation, and hyperandrogenism and menstrual irregularity is the first year post-menarche. The first year post-menarche irregular menstruation cannot diagnose the syndrome, but it is a risk factor to follow up with this patient or this adolescent. Hyperandrogenism and menstrual cycle from 21 and to 45 from 1 to 3 years after menarche, and after that from 21 to 35. Metabolic syndrome at this age and menstrual irregularity can diagnose can be risk factor for diagnosis of polycystic ovary syndrome. So these are the items which are very important to follow up the risk female adolescent for occurrence of this syndrome after that. Number 2, avoidance of overdiagnosis. Also 4 items, very essential for you. Number 1, pick up and the management of high-risk children. High-risk children, very important to manage earlier, to prevent اللي هو occurrence of polycystic ovary syndrome in adolescents. Awareness of feature of normal adolescent development, you should be aware that this is a differential diagnosis and they can mimic the criteria for diagnosis of the syndrome at age. And not consider irregular menstruation the first year post-menarche for diagnosis. Also, awareness of differential diagnosis for hyperandrogenism, combined hyperandrogenism and irregular menstruation. This 4 items very important for you to prevent overdiagnosis of polycystic ovary syndrome among this age. Pick up and the management of high-risk children, change lifestyle, and follow up this at-risk children. And I repeat for you, with epilepsy, premature birth, family history, and the prevention of child obesity, very important. If the child, if female, is obese at childhood, it is a risk factor for occurrence of polycystic ovary syndrome among adolescents if associated with family history. How to prevent childhood obesity? This is a problem in our community. Need cooperation between home, pediatrician, dietetic, and the schools. If these 4 places can interact with each other, you can prevent childhood obesity by taking snakes and other foods which are liable to obesity. Number 2, after that, awareness of features of adolescent development. You should be aware at this age that the feature of this age can mimic or can be differential diagnosis for the diagnostic criteria. Irregular menstruation can occur, and the mild hyperandrogenism, acne and hirsutism, and you should be aware this is a normal features, and you should be differentiate between the normal and the abnormal. Normal feature of menstruation and differential diagnosis, pathological hyperandrogenism, clinical and biochemical, you should be aware of this. And bad food habits, stress, and depression can occur at this age, but the first 2 items very important, and they can mimic the diagnostic criteria for advanced polycystic syndrome. You should be aware of the difference between these 2. The clinical hyperandrogenism occurs by severe acne, hirsutism, or alopecia and hair loss, but in the features of adolescents, it is very mild hair. About 70% of adolescents can occur for the clinical hyperandrogenism, which can diagnose the syndrome among this age. The biochemical hyperandrogenism, if you need accurate diagnosis, you may need indicate a high quality assay of testosterone, which is deficient in our labs in Egypt. But very important to say, a very important item and a specific lab for this, which can diagnose the hyperandrogenism biochemical and can differentiate between it and the normal features of adolescents. Number C, not consider irregular menstruation the first year Post-menarche, very important as irregular menstruation. The female comes by her mother, with his mother, and comes for you that irregular menstruation after menarche for 1 year. It is very important, not consider it very important to prevent overdiagnosis, and after that, you can diagnose irregular menstruation from 1 year to 3 years, and after that, by the length of the cycle from 21 to 24, 45, and after that, from 21 to 35. So irregular menstruation in the first year not important for diagnosis and can lead to overdiagnosis, and prevent this for prevention of this overdiagnosis. Number 4, awareness of differential diagnosis. You should be aware of the differential diagnosis of combined hyperandrogenism and irregular menstruation, not only polycystic syndrome. It can occur also by non-tumorous causes like hyperprolactinemia, hypothyroidism, ingestion of anabolic in the gym, and congenital adrenal hyperplasia, and also tumorous causes, the androgen-reducing tumors, ovarian and adrenal, and ovarian hair represent 1% ovarian tumor. You should be aware of this by virilization of the voice and the other manifestation of virilization. So you can be aware, you should be aware of this combination other than polycystic ovarian syndrome diagnosis. My conclusion, Mr. Chairman and dear colleague, polycystic syndrome presents during adolescence, but not always diagnosed at that age. And the accurate diagnosis of adolescent polycystic syndrome should start earlier by picking up at-risk children and prevent obesity, and also optimizing evidence-based diagnosis of adolescent polycystic syndrome need avoidance of under, over, and delayed diagnosis at the same time. This is the equation: how to prevent over and under, and at the same time prevent delayed diagnosis by proper diagnosis, and you should know the items of diagnosis and the differential diagnosis. My recommendation is artificial intelligence may be a valuable, effective, and efficient tool for accurate diagnosis of this syndrome among this age. And also now, avoidance of adolescent syndrome can be achieved by prevention of interaction between the two head theory, between the genetic and epigenetic factors among these females. Thank you very much.
Thank you, Professor Muhammad Imam. Now we are going, Professor Qasim Ali is going to present ethics in vitro fertilization.
Today we are discussing a very important issue about the ethical considerations in the ART or the assisted reproductive techniques. In this presentation, we intend to provide the clinicians with the major or some of the most important international guidelines of the assisted reproductive techniques regarding the ethics, and comparing them with the adopted or adapted Egyptian guidelines in the ART. In Western countries and Europe, there is a clear difference between what is religious and what is ethical. But here in Egypt and other Islamic countries, what is ethical is religious and vice versa. And since Louisa Brown was born from the first successful IVF trial, many ethical issues were raised. Mainly, this was up to 1980, where Sheikh Gad al-Haq, Ali Gad al-Haq, declared the legitimacy of the ART in Egypt, as long as medically and ethically indicated by the couple. And this was followed by many international syndicates and health committees on the years 2000, 1919, 1984, 92, and even the Egyptian Health Council held in Luxor 2024. And also they all agreed on one basic principle, is preserving the procreation and avoid mixing genes. We are discussing here the major guidelines regarding the ethics in the ART, including the Australian Health Committee, the European Society of Human Reproduction, and the American Society of Reproductive Medicine. And we have compared them with the other Egyptian guidelines, mainly derived from the Azhar fatwas, Islamic organizations, and Islamic Fiqh Council and Egyptian Health Council was held in 2024. The main basic principle and the main basic guidelines were updated and modified by the Australian Health Committee in 2024 and approved by other committees. They include autonomy, which means the right of the person to take the right decision, together with seeking the welfare of both the personnel and the newborn, which is called beneficence, by the way, avoiding new harm, which is non-maleficence, and consider any social relationships in decision making and minimizing any unnecessary interventions. And here, when discussing the ethics of unnecessary interventions, we have many issues to discuss. Let's say you don't have the right to do something under research unless you have told the patient and approved and took her consent to do something under research. We all hear about what is done in ART, like PRP, plasma-rich replaces, stem cell therapy, or something like this. If you do this and convince the patient that this is the solution, you are malpracticing and this is a crime. You have to counsel the patient and take her consent first. Also, these main guiding principles include justice, transparency, and privacy in all aspects, with lack of discrimination based upon any base. You shouldn't discriminate between the patient. This is on any race or any financial aspect or any social standard. Okay? We have to respect the embryo status, and we will discuss it a few minutes later, inshallah. The first step in ethics is information giving, which should be given verbally and in a written way after discussing all other options with the couple. يعني هنناقش كل الاوبشنز بما فيها الادoption of the babies. If the ART will not work, you have to discuss all if this is feasible for her or not. Also, the information should be given regarding all the costs of the procedure. ما ينفعش تقول للعيانة التكاليف كذا وتفاجئ بتكاليف إضافية. لازم تحصر كل التكاليف بتاعت ال ART قدامك وقدام العيانة. Counseling is very important. It should be done at each step, before, during, and after each step of the procedure, carrying the risks and the benefits in front of each other. Also, all parties involved in the counseling process should be attending. Okay? طبعا في third party في ال Western countries اللي هو third party donation is prohibited in Egypt, by the way. After this, the final step before starting the procedure is the final consent of the patient. The consent should be well informed, including all the parties as we discussed. This is the first consent of the procedure. A second consent should be written for storage and disposal of the embryos and the gametes, and another special consent for the third party if there will be any donations of embryos or eggs. It's prohibited of Egypt, of course. Unfortunately, regarding age limit is not specifically decided by any of the committees. There is no maximum age limit. Although many clinics in USA and Australia and Europe limits the ovum pickup to the age of 45 years and the age of embryo transfer to 50 years. But we are discussing this 50 years old mother. When she gets a child and the child, this will be 15 years old. How can she raise him up? This raises many ethical issues. Should we donate eggs to this mother? Should we do embryo transfer to a mother that above 50 years? This is a very debatable issue. How many embryos should we transfer? Of course, here in Egypt, something is not going very well. Single embryo transfer is the preferred approach all over Europe, Australia, USA, in women above less than 38 years for euploid babies. Euploid, they are non-mosaic, non-aneuploid, they are normal babies. The Egyptian Health Council in 2024 suggested that no more than 2 embryos are transferred to women above 38 years. But do we do this in our clinics? In our practice, do we do this? At first, in my early ages of IVF work, I have transferred 3 embryos to a Canadian patient. And the Canadian patient got pregnant in the 3 embryos. This is all malpractice for me. And she went to Canada to have her babies delivered. They were about to sue me, and they called me asking, how do you do this? Of course, they had delivered her 36 weeks and was laughing, but this is a malpractice. It shouldn't be done. 3 embryos is a crime. We have to follow these maximum 2 embryos, not more. Of course, the USA have made some adjustments to increase the number of the embryos, to add more embryos to be transferred according to the patient herself. If the patient is old age, or the embryos were of bad prognostic criteria, or aneuploid babies, they are adding 1 embryo extra for each risk factors. They can reach up to 4 embryos in the women above 42 years old. It's ethically to collect and preserve gonadal tissue from a diseased person, to preserve it under the condition provided that they are not for donation and we cannot harm the person we are collecting the gametes from, and they are the best way to preserve his fertility. Actually, in Egypt, we don't have clear recommendations for preserving this in children, and collecting a gametal tissue from a dying person in Egypt is prohibited. Sex selection is still allowed in Europe and Western countries only for medical reasons. We shouldn't allow it for family balancing. Also, although in Canada they allow it for family balancing if the parents have 2 or more of the same sex, but it's mainly should be done for medical reasons. Here in Egypt, it's done without any medical reasons. Also, sex-selective abortion should be limited to a medical reason that endangers the person's life. Or, here in Egypt, it should be based on a reliable PGT testing. We cannot do it without PGT testing to abort a sex-selected embryo. The pre-implantation genetic testing is used to minimize the rate of miscarriage and increase the rate of success of IVF. But there is no universal evidence suggesting its worldwide use. But here in Australia, they limit it to 2 uses. Either we could do a tissue typing for stem cell therapy for a future parent, or we can use it to minimize the serious condition that endangers the person's life, not to increase the rate of success from the IVF or decrease the rate of miscarriage. There in Australia, they have specific recommendations from the PGT. Can we transfer in Egypt an aneuploid baby? If you found an aneuploid baby, would you transfer it in Egypt? The answer ethically is no. But the American Society has suggested that we can transfer an aneuploid baby or embryo only under the condition that it will be transferred with another euploid baby. But why? Why are you saying this? Because there are 3% incidents that the PGT result would be wrong. Also, some cases there are mosaicism, and only the euploid cells would proliferate to produce a normal healthy embryos. So you can transfer an euploid embryo in USA, but as a double embryo transfer with another euploid embryo. Here in Egypt, it's prohibited. It has to be noted that all the products of the gametes or the products of IVF are an ownership of the couple, and any decision should be mutual. Of course, it's allowed in Western countries either altruistic means without compensation with money. Donation of eggs or embryos, can be altruistic without money or can be donated with money, but any of those forms, even including surrogacy, is prohibited in Egypt. Mitochondrial donation is a new approach licensed in Australia 2022. This approach was licensed to decrease many of the mitochondrial diseases that are seriously that will endanger the person's life. But there is no evidence supporting its worldwide use in Europe. Of course, we don't have mitochondrial in Egypt. Fetal reduction is still ethically and religiously debatable. In Europe, they use it as a last resort to prevent the high-order multiple pregnancy complications. Here in Egypt, we don't have a rule to regulate it. We have to have specific rules to regulate the fetal reduction. IVF labs should provide safe storage and adequate identification of the gametes. ما ينفعش كل الجاميتس تتلخبط. لو ما فيش نظام سيستم في IVF lab شغال كويس, this will be ruined. And we can provide policies to resolve disputes between the parents. And even if a person died in Europe, either there is specific agreement with this person to use his gametes afterwards, or it will be discarded. Here in Egypt, marriage is a life sentence contract. When the marriage ends by dying or by divorce, all embryos should be discarded. What I've told you about respecting the embryo research. In America, they respect the 14 days stage of the embryo. They say that after 14 days, it's unethical to do research or cultivate embryos more than this if you are not going to transfer it. They have extended this to 28 days. The research is allowed, but not aiming to change the genetic characters of the embryos and not aiming to do any harm to the embryos, and respect this status. Also, Professor Dr. Gamal Surur added that we can research on those embryos provided that it can be done in a legalized health institute and not for commercial uses. Prioritization. President Trump in USA, the IVF was not funded actually till January 2025. President Donald Trump has started to do funding, but the funding has to be prioritized first. Severe medical disorders and long duration of infertility has the prioritization of the IVF. Also, cancer patient or dying patient need to be prioritized. Here in Egypt, we don't have this prioritization. اللي معاه فلوس هيعمل IVF، اللي معاهوش فلوس مش هيعمل IVF. In poor prognosis patient, counseling. Even if adoption was done, the adoption is legally accepted but religiously restricted. There is no inheritance in Egypt, but adoption is an easy option outside. Summary: more rules and restrictive rules in Egypt should be done to avoid what the chaos in Egypt that happens about the sex selection, the fetal sex reduction, and other procedures. Last word, please, when choosing the protocol of the IVF, don't care of the amount of eggs you get. In a PCO patient, it's a crime to use a long protocol. In a PCO patient, it's a crime to use a long protocol. The flare protocol or the short protocol, although gets more eggs, obviously, but it has an association with more atretic follicles. So in the final number, you will get the same M2 eggs you will cultivate, and you will have the same number of embryos. So don't deceive the patient by doing a short protocol to get more eggs. It will get the same number of embryos at last. Thank you.
Thank you. Professor Basim Ali. Professor Hamdi Ahmed is here. Okay. He's going to present autologous rectal sheath graft for apical prolapse management is synthetic mesh essential. A case is evaluating the mesh-free vector fits.
Thank you for the organizing committee for presenting this presentation. I will present today an alternative for mesh in management of apical prolapse. The pelvic organ prolapse is the center of pelvic organs throughout the vagina. It affects about 50% of Paris women. It's a significant impact on quality of life, and there is high surgical burden, about 11 to 19% lifetime risk. Uterine prolapse is a specific form of apical prolapse where the uterus itself slips from its position and descends into or beyond the vagina. This is the anatomical level of support. We have level 1, which is an apical support, level 2 and level 3. Then our concern is about level 1, which is the cardinal iliopsoas ligament, the primary uterine support. Consequence of apical failure result in uterine prolapse, which can be symptomatic or asymptomatic. The current gold standard for management of uterine prolapses or vaulted prolapse is abdominal sacral colpopexy. It attaches the vaginal apex or the uterus to sacral promontory, and it uses synthetic mesh to support high success rates reaching up to 95%, durable long-term outcome. But there is a problem of the mesh. There is a foreign body inside the woman's abdomen. Significant complications of synthetic mesh erosion, 4 to 10.5% incidence, exposure through the vaginal epithelium. Infection, local or systemic, may require mesh removal. It's around 2 to 3%. Chronic pelvic pain in around 5% of cases, and dyspareunia. So, pectopexy, a mesh-based alternative. Sacral colpopexy can be difficult for some surgeons, and it involves dissecting the area of sacral promontory where the iliac vessels are present. So another operation was introduced in 2010 by Gartner Noah. It's called pectopexy, where we use the iliopectineal ligament on both sides for suspending of the apex of the vagina or the uterus. It's more simple and gives equal results, but still relies on synthetic mesh. So another alternative is for the mesh, will be discussed in this. Introducing autologous rectus fascia sheath graft. Rectus fascia is a strong fibrous connective tissue that encloses the rectus abdominis muscle, providing structural support to the anterior abdominal wall. Its key advantage is it's a patient-owned tissue, eliminating foreign body reaction. It's biocompatible, natural integration of surrounding tissue, strong, excellent tensile strength for durable support, available harvested during the same procedure, no additional costs for the surgery. So my approach will be pectopexy plus no synthetic mesh plus the graft, safer and durable repair. Key advantage is that no foreign body, strong fascial support readily available during surgery and cost effective. We utilize this anatomical advantage of pectopexy and eliminate the use of synthetic mesh and potentially preserve normal pelvic anatomy. Study design, it's a retrospective case series. It was done in Armed Forces Hospital in Saudi Arabia. Study design was between October 2022 to 2024. It concluded around 13 patients with symptomatic apical defect, POP-Q stage more than 2, point C. Follow-up of around 12 months. This is the steps of the procedure that will be shown in the video later. Primary endpoint was anatomical success, where stage point C is less than stage 0 or equal. Secondary endpoint is graft-related morbidity over 12 months. Patient demography, the total number of patients was 13 patients. Mean age was 47 years old. Mean parity 4.2. Body mass index 28.3. 5 patients had previous pelvic surgery, and mean follow-up was 16 months. Success rate of this case series was around 84.6%. 11 of the 13 patients had success rate in these cases. Stage 0, 11 patients. Stage 1 by POP-Q, 1 case, and 1 case had recurrent after surgery. Safety profile, no graft erosion, no infection, no chronic pain. We have one case of incision hernia after 4 months of the surgery. Mean operative time is 104 minutes, mean blood loss 134 ml, and mean hospital stay was 2.3 days. Symptomatic improvement is 11/13 or 84.6 patient. We have a fertility case. Patient came with, she was about 42 years old with 10 years of secondary infertility. She had stage 3 trial collapse by POP-Q system. And after surgery, 9 months after surgery, she got pregnant and delivered by cesarean section. Spontaneous pregnancy. So, autologous rectus fascia graft, patient-owned tissue, eliminating foreign body, no erosion, efficacy 84.6%. But we have 2 problems: the incisional hernia, and it needs laparotomy. The synthetic mesh is ready to use. Approach minimally invasive can be in laparoscopy or robotic also, but there is an erosion risk up to 10.5%. Regulatory concern, FDA classification as moderate risk, and foreign body inside of it. So our key findings is mesh-free pectopexy gives considerable anatomical success rate. Synthetic mesh may not be used, may not be essential after that. Safer alternative. Of course, we need multi-center trials, long-term follow-up, and other comparative studies, and we need to try to do it by minimally invasive laparoscopy approach. This is the video. It's a dibifenstine incision. We open abdomen and free an area. We take the graft by vertical midline, not from side to side. The graft is taken a rectangular shaped graft, taken from the upper border of symphysis up till the umbilicus. Here we are making a mark. The graft harvesting is done by a plastic surgeon. He was assisted in the surgery. It's around 2 centimeters. And its length would be an average about 12 centimeters. We dissect this flap from the muscle beneath it, in the midline, as I mentioned, not from side to side, not from umbilicus till the edge of symphysis pubis. We start from the symphysis pubis until the in the midline, the electric is very strong and can tolerate big stitches. Then we enter the cave radius, exporting the peritoneal ligament on both sides. 2 stitches are applied to non-absorbable sutures in the peritoneal ligament bilateral, just anterior to, we dissect as lateral as possible, just anterior to the external iliac vessels. Two unabsorbable sutures on both sides. In this case, needed hysterectomy, so we entered that, and after that, and after performing hysterectomy, we suspend. Now we are making a tunnel between the intraperitoneal and extraperitoneal. After the hysterectomy and dissecting the bladder downward, we hold the round ligament and dissect from intraperitoneal to the extraperitoneal space. We're using this rubber as just a guide in this tunnel. See here, this is the edge of the bladder, just medial to round ligament. The tunnel is now made bilaterally, where the graft will be passed to ends. Now this is the graft. This is the midline of the graft that we harvest. We are fixing a non-absorbed suture in it also. Now we'll fix it to the anterior wall of the vagina after a hysterectomy was performed in this case. Take multiple suture to fix it to the vaginal wall. Now we pass the three ends of this in the tunnel that we made. We'll tie the sutures that we've taken at the end at the beginning of the operation will be tied to the three ends of the graft. This is the end of the operation. After fixing these two ends, we will just cover the gap by the bladder, and then close the pneumonia. Close the incision using non-absorbent sutures. Thank you.
Thank you. Now, next presentation is measuring what matters of quality in gynecology surgery. Dr. Boraz Abenstein is going to present video talk.
So, dear Chairman, ladies and gentlemen, it's a great honor for me to talk about this very challenging and very important subject of measuring quality in gynae surgery. I'm very sorry that I cannot be with you this time, and I hope that it will be possible to meet you in person next year at the same occasion. I have no disclosures regarding this presentation, and I would like to jump into this matter, the matter of quality, because quality is what matters, and we all want to deliver good quality to our patients, but we don't know about our quality as long as we do not measure this quality. Why does it matter to measure quality? Gynecologic surgery has become increasingly complex during the last 2 or 3 decades. And patients, policymakers, and care providers, they all demand accountability. We do know that better metrics mean better care, better outcomes, and better efficiency. And quality, for sure, is multidimensional. It's not just about clinical success. We know 3 pillars of quality measurements. And these 3 pillars are structural indicators, process indicators, and outcome indicators. And these 3 pillars carry the quality of our care. And when we look at structural indicators first, I have some examples for you that may be the availability of minimal invasive equipment. It may be the availability of robotic systems. Certificates of surgeon training can be a structural indicator, or the availability of a dedicated gynae surgery team, which does not serve other surgical specialties. We do know that the quality of our surgery becomes better when we deal with the same personnel every day. A very challenging subject is the procedure volume per institution and per surgeon in this aspect. And that's why I would like to stay with this subject a little longer, because it's so complex and it's so variable when we look into different routines, into different countries. So, for instance, the volume for gynae oncology is supposed to be 150 oncology cases per year for an oncology institution, which is a fair number. It doesn't say primary oncology cases, it just says 150 per year, considered a volume which is enough to deliver quality. In the Netherlands, they proposed 20 ovarian cytoreduction surgeries per year per hospital to be considered a number to guarantee quality. In urogynecology, it's a whole variety what you find in literature, and it might be a good approach to use these 50 mid-urethral slings annually per surgeon. That would mean one sling per week, which I think can be enough. And when you look down to the standard benign gynecology cases, I think we can all agree that 1 to 5 cases per year is a very low volume and probably not enough. When we look at the proposals from various societies, the ESGO asks for 15 or more radical cervical cancer surgeries per year per center as a good volume, or more than 20 sentinel lymph node procedures per surgeon per year as a good number for guaranteeing quality. In the States, they questioned how many robotic cases should be performed by one surgeon. And they said about 12 per year, so meaning 1 per month. I don't know whether this is enough to be really an expert and to gather enough expertise for the robot. But that's what you find in literature. In Austria, the Austrian Society of Gynecology, they said that at least 24 new ovarian cancers should be operated per year per institution to deliver good quality for ovarian cancer patients, and less than 10 per year is not enough. When we look at urogynecology, the societies, they do not speak about volume threshold, they just emphasize on specialized centers. So why do structural indicators matter? Because we do know that high volume is linked with better outcomes, and high volume enables the adherence to best practices. Moving on, we go to process indicators for quality. As an example, time to surgery for emergency could be a good process indicator. And there we find categories, and we use that also in our hospital, differentiating between immediate and life-saving category, urgent, semi-urgent, and early categories, saying that for this immediate category, which would deal with life-threatening conditions with an unstable patient, this patient should get surgery in less than 30 minutes, whereas an urgent case would be a stable case, but in a serious condition, having surgery in less than 2 hours. Semi-urgent, less than 6 hours, and early, less than 24 hours. We use these categories in our hospital, and I'm sure many of you do as well, but we also have to check whether we reach these goals. So we have to produce data and to check these data. Another process indicator could be the use of preoperative antibiotics or the compliance to enhanced recovery after surgery protocols, which are widely used, or the documentation of informed consent or team timeout procedure documentation. I show you a preoperative transfer checklist, which we use in our hospital. And this checklist, a patient would not see the OR before each box has been checked. And if one box is missing, then the patient goes back to the ward and will not see surgery on that day. Or another tool which we use is this team timeout procedure. And when I brought you this example, we check this regularly. And a supervisor comes into the OR and checks how we perform team timeout procedure. And this was in October 24. And you see that we have not reached 100% with all indicators. And in March, we became better, pointing out that the team paid attention to the various aspects in the strong desire of delivering quality to the patient, which we all want. So process indicators matter because they reduce variation and errors, and they are a very good surrogate for safety and professionalism. Let's go to outcome indicators, which is equally important. We do have traditional metric outcome indicators like intraoperative complications, postoperative infections, length of hospital stay, readmission, or even mortality. And you find good benchmarks for these various indicators in literature. Just for instance, readmission of a patient during the first 30 days after surgery, it should not exceed 6%, with 40 to 45% due to infection. So this could be a benchmark. Important for us is that we set our benchmarks for our departments, because we do have various patients, we do have various situations in our countries. So we have to set these benchmarks for us primarily in order to accomplish this quality control in the best way. And then above traditional metrics, we know specialized metrics like pelvic floor repair quality, for instance, a very important aspect, and sexual function outcomes as another specialized view of quality, outcome quality of our patients. And when we use these metrics, we must adjust them for case complexity. Patient reported outcome measures is another way to look at quality. And I think it's one of the most important because it comes directly from the patient with no further interpretation. It only captures what matters most to our patients. And that's why it's so important. We may look at pain, fatigue, urinary or sexual function, quality of life, and we can use different tools. Those questionnaires, which are validated questionnaires in different languages for different countries, which we can go ahead and right away use them, ask our patients to fill in how they feel. And patient experience, patient satisfaction, focus on how care was delivered. Another very important aspect to look at quality. So, for instance, these patient experience and satisfaction questionnaires, they ask, how was the communication with the patient? Has the patient been involved in decision making? How long were the waiting times for an appointment, for surgery, for a surgery appointment, for instance? How long was the waiting time in the outpatient department? Important aspects to look to prove quality of service. Or was the patient treated with respect, with dignity, with enough cultural sensitivity? There are tools to measure that, and these tools are widely used in the States, not so much in my area, but preparing this presentation, I became convinced that we have to adapt to these tools also in our area. Satisfaction, of course, is not 100% resembling quality, but poor experience or poor satisfaction of our patients can flag issues we have to deal with when we notice them. So, as an example, for laparoscopic hysterectomy, you may create a dashboard for your department, looking at a structural indicator, how many surgeons are trained in minimal invasive surgery of your department. Is there a good compliance to preoperative antibiotic timing? How high is the complication rate? And we have to set our thresholds here. It can be 5%, it can be 7%, but it's important to get notice and to get the data, as well as for patient-reported outcome measurements or satisfaction measurement of patients after laparoscopic hysterectomy. I think it's very valid to get these data for your own judgment of your own quality, which you deliver in your departments. It's challenging. This quality measurement is very challenging because data collection is difficult. It's a burden. It needs personnel. It needs staff to collect data. We have to motivate our staff to help us to find these data in order to be able to measure quality. And then we need to standardize across the various systems, which is also a challenge. Another challenge is that low event rates need large data sets. Fortunately, the complication rates are low, but this just tells that we need large data sets in order to be able to see results. And after all, patient expectations do not always reflect reality, and we have to balance that. The patient expectations, we have to get that into a right range. How can we see the future of quality measurement? I think we are not far away from digital dashboards, which can be integrated into electronic medical record systems of our hospitals. I also think that we need a longitudinal tracking of patient-reported outcome measurements, and that AI, artificial intelligence, will be a good help in order to be able to predict for risk adjustment. I have to address the international associations, because those can best create benchmarks which can be used globally by institutions, by hospitals, when they want to see how is their quality compared to others in the same field. I think that quality has multi aspects. Quality looks at outcomes, at processes, structure, and it looks for, after all, for patient. How does the patient feel? It integrates the patient's voice. And in order to be able to hear the patient voice, we need these patient reported outcome measurements and experience protocols, which are filled out by the patient. And we need to be able to see these data. It's not enough just to collect the data. We have to work with these data because only these data can drive improvement. I would like to conclude with William Bruce Cameron. Cameron was a columnist, a humorist, but also a sociologist. And he did a nice play with words, saying not everything that counts can be counted, and not everything that can be counted counts. And I think this is very true for medicine, because medicine is an art. And of course, data are mathematics and data are statistics, and they help us to see how the quality of our service is. But this does not say that we have to give up on the art of medicine, on the art of treatment. I would like to thank Cameron for this nice and philosophical sentence, and I would like to thank you for your kind attention. Thank you very much, and I hope to see you in person next year at this very nice meeting. Thank you once again.
Now, anyone has any question? Thank you. Now we are closing the session.